She just wanted to put a needle into the patient just for shits and giggles.
Yeah.
Oh. Yes, just for shits and giggles. Hi everyone, welcome back. I'm Dr. Peggy. I'm an emergency medicine doctor.
I'm James.
You can call him Dr. James too, but this is James. He's my husband.
Internal medicine.
He's an internal medicine doctor. I'm reading your comments. Thank you so much for the nice, encouraging remarks. I do realize people have said other doctors have been responding to the show, but I'm the only female doctor and female emergency medicine doctor that's responding to it. So you know what? In honor of International Women's Day, I appreciate that. Thank you. I'm honored to represent women in medicine and happy to be here and share our thoughts.
I'm just shocked there's more male doctor streamers out there than women. That's just shocking to me.
Is it streaming? I don't know. But I mean, commenting. Well, I don't know. Maybe women are still subject to all of the double standards of having it all, meaning working women, but also still having expectations of running the household, the mental load, raising children. Who knows? I don't know. I feel those kinds of burdens for sure. And my field is still a male-dominant field. Even though there are a good amount of women in my field that I know personally and work with, it's still male-dominated. Are you ready to go?
Sure.
Episode 3.
The chances are it's a demonic possession.
About the same as you going a whole hour without saying something stupid. For Christ's sakes, go already. You're like having a kid I never wanted.
At work, we talk about this, like, hey, have you seen the show? You know, the Pitt. Then the charge nurse is like, let me say that charge nurse looks too relaxed. I mean, granted, it is only the 3rd hour of their shift, but the charge nurse in the ER is bombarded with everything because they are in charge of the flow of resources, of the bed spaces. I mean, the doctor is working alongside and helps to make those decisions. The charge nurse is kind of like the in-between everyone. All the nurses go to the charge nurse. All of the doctors go to the charge nurse. The techs, everyone, they're kind of like the middle orchestrator, and the doctor, yes, is there to kind of help with the triaging and tell the charge nurse where the patients are going or who's sick or what. But the charge nurse knows all. And million phone calls, everyone is coming to them, and it's stressful. And I wouldn't want to be them. I mean, not to say I wouldn't want to be them, but it's a stressful job. Also, a couple roles that are missing that I haven't seen yet in the series. Anything you noticed that you haven't seen?
No clue.
Respiratory therapy.
No, they had one. They had one doing the event, didn't they? I can't remember.
But there's no, maybe they're in there in the background, but there haven't been much of an active role. You know what I mean?
Yeah.
In the emergency department, they're very active with us. We need them. We call for them. We say, where's respiratory therapy? I get to know my respiratory therapist very well. In fact, I'm very good friends with my respiratory therapist from when I was training. And, well, not every hospital has scribes and emergency medicine technicians. We call them techs. But some of them do. So the hospital that I trained at, kind of like this academic center, did not have any scribes or techs. So that could be accurate. And then unit secretaries. Unit secretaries, I feel like in the community, non-academic setting, non-teaching hospital like this, are also super important. The unit secretary and the charge nurse and the attendings, those 3 are bombarded, answering calls, dictating things, and trying to make the department run. The unit secretary is calling the transfers, calling for admissions, answering all the phone calls. Nuts. It's just nuts. That resident was talking about how, like, oh, use up the bed space, move these people along. He's kind of, what do you think his attitude was like? How did that make you?
Well, I mean, he's kind of being realistic. He's like, hey, we only have so many ICU beds. You should use it for somebody who's actually might be salvageable. Truth is, though, there's probably already multiple people up in the ICU that are already unsalvageable. But anyway, but his whole idea is, what are we spending time with this? But, you know, that's a little harsh for someone who just lost their kids, so that's pretty bad.
It is harsh. I think in emergency medicine, we kind of have to shut off the emotional side of our brain while at work, because that's the only way you kind of deal with these types of things every day. And if you don't become non-personal, just job only, professional only, it's too hard to go through something like this and try to act normal. So you have to just kind of compartmentalize and deal with it later. I'm not saying that's the healthiest thing to do, but that is the most efficient and best way to get through the day. And also, just like what you're saying, like some people in the ICU, there's a chance that something can change or improve or save them. And then there's some people in certain situations in the ICU, especially where the prognosis is already terrible, poor, it's not going to change. And so that's in the situation. So, we have to, it's a little bit dark, but there are times where we think to ourselves, when we have multiple sick people and we're looking at all of the critically ill people, we think, well, we know which ones have a chance or might have something, that we can help with, and which ones, unfortunately, are already long past where we can make a difference. And then sometimes it's the things that we think in our field that we don't really share with the public world is thoughts like that, where it's like, oh, well, that patient died. At least we have another spot for this patient now. So it's very impersonal, it's hard to be like that. I'm not saying that's right as a human being, but that's just kind of what it boils down to when you have to treat it like business and work as usual. I don't know. It's obviously it's devastating when anyone is lost, but certain people, certain patients, certain cases hit us harder, hit us more personally different than other types. It's just different. I think when someone comes to you elderly, has a long life, and they're dying, it's not as difficult as someone that's young and suddenly found down, and in that case, like brain dead. It's just very different.
Yeah, that's why I can't do pediatrics. I would like.
Oh, right. Yeah, exactly. Like in pediatric ICU, pediatrics. We didn't go into pediatrics, so like we just find those sick children's just extremely, traumatic, hard, sad, super sad.
Yeah, it's like unbearable.
Okay, but I love kids. I actually really love pediatrics. It's very sad to lose a kid.
Don't suppose you'd let me try a pericardiocentesis?
For what?
For practice. In case it's tamponade.
None seen on ultrasound.
This is a teaching hospital.
It's not a cadaver lab.
What do you call this?
So I'm talking about doing a procedure on this patient called pericardiocentesis. And it's the one you see in episode 1 in a different patient where they put the needle in and take fluid out from the space around the heart, the pericardium. And they were like, why would you ask to do that? Because this patient doesn't have that problem, the pericardial effusion. And then the intern, who's that girl, was basically saying, why not? This is a teaching hospital. So she's just being super aggressive, like, well, the patient's dead already, so why can't I just do all these procedures that I never get to practice and try? Which is not a very compassionate way to think about it.
I just think it doesn't make any sense.
Yeah, he thinks it doesn't make any sense, which it doesn't make any sense because there's no indication for it. And
No,
also,
it's not just not. It is impossible to do. You can't get.
She's not going to get any fluid out, correct. She just wanted to put a needle into the patient for shits and giggles.
Yeah.
Oh. Yes, just for shits and giggles. And there are people that are aggressive about learning like that, and I'm not one of them. And I don't agree with that, so I would not allow that to happen. But sometimes crazy things happen in teaching hospitals, it's true. I did residency at a trauma center teaching hospital, and thoracotomies are when they cut open the chest and the ER with the trauma surgeon team, and they open both sides to gain access to the heart to try to stop any bleeding emergently. And that's indicated in any kind of penetrating trauma, like for example, a gunshot through the chest, stab through the chest. But I've definitely seen plenty of thoracotomies on blunt trauma. And not to say it's never indicated, but it's basically almost zero chance you're gonna get someone back. The medicine behind it is meaning like, there's not like one hole you could just patch up the way you do with like a gunshot wound or a stab wound. And that's when the indication for opening up the chest is, to try to get to that area and close it up. That's how the residents get, or the trainees, it could be fellows or whatever, that's how they get the training and the experience to do these things for when that time comes, then they can do it. But have I ever seen a thoracotomy bring back a patient that had a cardiac arrest from blunt trauma?
Nope.
I haven't.
No.
I mean, ask a trauma surgeon, they see more, but I haven't.
Why? Your friend couldn't wake you. I'm right here, Jenna.
Came to with 1 spray of Narcan.
What'd you take, Jenna? We need to know in order to treat you properly, okay? Do you know what she took?
No.
This could be a sign of something really serious, and we're gonna have to do a lot of tests that you
Okay,
really
it's
don't.
like half a Xanax.
It's okay. Okay.
Alright, Xanax does not respond to Narcan.
Maybe, like, I think maybe she just got it off the streets and it's laced with fentanyl, which is a common thing. You get street.
Lace Xanax with fentanyl?
Oh, any kind of they just cut it and they put it's just got like fentanyl in it to make it more addictive.
I just thought it was like already pill form, but okay.
No, we're not
I
talking about like
clearly
an actual prescription Xanax. Like this is like street form.
Oh, street Xanax.
Yes,
I see.
you're right. Actual prescription of Xanax should not make you have an opioid overdose.
Yeah. Also, if they took it last night, then it would have worn off by now. Even fentanyl would have worn off by now.
Yeah, fentanyl is very short acting, so she's not being. Something's not adding up, is what James is saying with that story.
Yeah.
Does anybody have anything that they wish had gone differently?
In the hall. You should have been on a cardiac monitor. We would have caught the arrest right away.
That's true. But there was no indication for monitoring.
Then we should have admitted to cardiology.
We did an EKG, we did a troponin. He had a heart score of 3.
1% chance of an adverse cardiac event in the next 30 days.
Standard of care is to discharge with outpatient follow-up.
Okay. That's it. Let's go save some lives.
That was a debrief after the cardiac arrest. They pronounced the patient. We do that in the emergency department. That does happen. It doesn't always get to happen though, depending on what's going on in the emergency department. Obviously, if there's multiple sick, dying, unstable patients, you don't have the time to talk about, to kind of sit down with a meeting with everyone. Everyone's running in a million directions. They have a million other patients to take care of. So it is very nice. It's great to do it. It's important to do it when you can. Sometimes you might have to find a different time, like, oh, hey, let's debrief after our shift or something like that. But again, everyone has different shifts as well when they're coming on and coming off. So what they were talking about was this gentleman, they mentioned heart score, risk of death, and all these things. They're basically talking about these tools that we as doctors use to talk about their risk factors, right?
History of coronary artery disease, past MI, risk factors. Don't think we need to go into too much detail. EKG findings, troponin levels. Let me say anything. I think.
There's age. That's it.
Oh, age. That's right.
Yeah, it's basically lots
factors.
of different factors, and in terms of the patient's background, their findings today, their clinical findings, and all those things, you kind of weigh the whole big picture, and you determine if someone is low, medium, or high risk of having like a heart attack, for example. And they're tools, and they're researched, and they're well backed up by research, but there's always an exception to the rule.
Yeah. Yeah, 1%.
Yeah.
They also don't know if that was actually from a heart attack. It could have been from anything. I mean,
Yeah,
cardiac
true.
arrest or was it a PA arrest or was it a AFib? They didn't shock him, so
They never shocked him.
it's probably a PA arrest. So very well could have been non-cardiac.
Yeah, so we don't know exactly what happened. Dr. Robbie says he thinks it is, or he didn't actually say, he said it was a cardiac event. But in reality, when someone passes away like that, especially in front of us in the emergency department, and I really cannot tell someone this is the definitive cause. Rarely, really rarely, unless it was like they bled out in front of me and I saw something happen, but suddenly just not waking up and having cardiac arrest, I'm not a pathologist. Those are the ones that are the specialists in determining the cause of death. And when people ask me or I have to fill out what is the cause of death, in the emergency department immediately, all I can tell you for sure is it was cardiac arrest, right?
Yeah. Filling out cause of death is so annoying because they always ask for a very specific answer, and sometimes it's very obvious, but like I would say at least 50% of the time you're just like, I don't know, the heart stopped.
Right. How are we supposed to know without actually going into the body, without actually having results, without actually the patient being on the monitor? All these things are unknown. So I don't like to make guesses in medicine, absolutely not, especially for cause of death, something that's so important like that. And I guess the point is there's always exceptions to the rule. So even though this patient was technically low risk of having something like a heart attack, or you never know, either it wasn't a heart attack or it was, and it was one of those rare instances. And it's scary. That's one of the things that is a big negative about my field is that we walk around scared that we will bump into that one exception to the rule. We practice according to standard of care, standard of medicine, according to what the research has shown, what we're trained to do, but there will always be exceptions to the rules. And we talk about them, we learn from other people's like stories of exceptions to rules, but those are anecdotes again. These are not research backed. These are just that one time I had that one patient and they showed up like this and it was this. And it's like, what? That's a mind-boggling story. And we all have stories like that. And it's always like a big surprise, and it's terrifying to work in this field where you don't know what you're gonna get. The phrase we like to say, it's like walking in a minefield with clown shoes. You're like, oh, I really hope I don't step on a mine. And you just don't know when it's gonna happen. Just bad luck.
So for the apnea test, we keep him on 100% oxygen, but the ventilator won't be giving him breaths.
For how long?
For 10 minutes, we'll monitor his carbon dioxide levels, and if they come back way too high, that would mean that there's no brain function at the most fundamental level.
Have you ever done an apnea test in the ER?
No,
Yeah.
I've never done an apnea test in the ER, so not realistic.
Yeah, that's not realistic.
There's no way. This is ICU level stuff.
Yeah.
This is intensivist pulmonology ICU level stuff.
I mean, it is pretty easy actually, but they just never.
Framing nail incident with deep penetration of the left chest. Small pericardial effusion, but no evidence of tamponade.
Not yet.
Somebody talk to me. Do I need a priest here?
He's tachycardic with borderline BP. He could decompensate.
Stand by with 2 units, whole blood. Garcia here.
You're gonna nail through your chest into your heart and not have a pericardial effusion.
She has one. He has one, but it's not big enough yet. It's collecting. She had a small one.
Can we intubate him first?
Sooner the better for all of us.
Great. 120 of Sux, 100 of ketamine. Javadi, you're up for this one.
Really?
Now, let's go.
You guys intubate as a medicine?
No, that's not realistic.
Yeah. I'm sure it has happened. I'm sure there is some med student out there who got lucky on to do it. But
Well, if you were to give it to a med student, it wouldn't be this guy's case. You
yeah,
know?
yeah.
You
that's
would
true.
give.
You get the most stable
Yes.
person ever.
Yeah, if you're gonna let the lowest tier trainee do a very important procedure like intubation, you give them the more stable patients or the more standard ones. But someone with something sticking out of their heart needing to go to the OR, that's senior level stuff.
Insert the tube around the bend.
You stole my med student from Triage? How's she doing over here?
Doing pretty good.
And advance through the cords.
Good job.
Thanks.
That wasn't realistic. They didn't have a stylet in the endotracheal tube.
Oh,
She just put an empty tube in. Usually we have a stylet to hold to help guide it in and then take a stylet out. That's okay though. It's not that far off from reality.
Dr. Garcia, do you think
Trauma surgery gets left-sided, thoracotomies. ED gets the right if we need to extend.
Glove up, girl. You're on suction.
Did he become hypotensive? Why are they suddenly doing this?
Yeah, he became sensitive like in the 70s. 72/38.
Nails intact. One piece.
Shoot forceps. Opening the pericardium.
Single puncture wound to the left ventricle. We've got a finger on it.
First unit is in, pressure's up.
I mean, it is realistic though that the trauma surgery and emergency medicine, they like to talk about which side they'll get to do the thoracotomy. And the thoracotomy is, like I said earlier, it's the procedure where they open up both sides of the ribs, spread it to get to the chest cavity to access the heart.
ST elevation in the anterior lead?
More than 7 millimeters.
Mr. Gelland, you're having a very big heart attack right now. We're going to send you up to the cath lab. A cardiologist is going to unblock that. We're going to put a catheter in this artery right here. We're going to shave the hair with a clipper.
I'm not doing the cardiac cath consents.
No, it's cardiology.
Yeah, so when we see a major heart attack like that, where they see that on the EKG, it's like a classic big heart attack, there's like a direct line to the cardiologist. It's activate code STEM. It's very time sensitive because it's a measurement that it's to improve patient outcomes, and the hospital gets judged on the time. So it has to be fast. So we call the cardiologist immediately. If they're at home in the middle of the night, they drive right in real quick. But usually daytime they're already around. And I don't do the consents. It's the cardiologist that does it because he or she is the one that's doing the procedure.
Yeah.
I don't want to go into psychiatry. I want to be here.
Being here means no matter how good you are or how hard you try, you're going to make another mistake. And someone else might even die. That's called being an emergency medicine doctor.
Clown shoes in the minefield.
Mm-hmm.
We can do an imaging test called a cerebral perfusion study.
Then let's do it.
But you have to understand that would be the last test, what we would do. If it comes back that there's no blood flow to Nick's brain, it would confirm beyond a shadow of a doubt that there's been brain death.
Wait, is the only test you need to do a cerebral perfusion study? Then you don't need to do any of these other things?
I thought the apnea test alone was enough.
Oh, okay.
But again, that's usually more of an ICU thing, but
Yeah.
I thought the apnea test was sufficient.
Yeah, this is all very new to me because I don't diagnose brain death in the ER.
Mr. Spencer at Central 9.
There is some family here. Jabati's mom is a surgeon upstairs.
Really?
Yeah.
Oh, that must be so nice.
Hey, someone's finally
You
charting.
kidding?
Yeah.
I don't know about your
Someone's
mom,
finally
but
actually
I
writing
would
a
not
medical
want mine
chart.
working within 100 miles of. Oh, in case you didn't realize, I use sarcasm and comedy as a shield, or so I've been told.
Thank you for opening up to me.
They're like such caricatures of characters.
Yeah.
Like they're so.
Is she vested or is she intern?
They're both residents.
Are they both residents?
Yeah, they're both doctors.
Hey, there's no scrubs in here.
Yeah, you have to put your old ones in before it'll give you a new pair.
What?
Those are very nice free scrubs.
Oh yeah, we wouldn't have fig scrubs in the hospital scrub dispenser. That's correct.
Yep.
Because they're hospital scrubs that are the public scrubs for the employees are not quite as nice as the ones we're wearing.
Did you try calling the school?
He didn't show up for class.
Any idea where he might have gone? Friends, relatives?
We don't have any family in state. And David,
Doesn't.
he doesn't associate with anyone.
Also, we would have definitely discharged his mom a long time ago. As soon as the mom was like, I just made myself sick to bring my son to the hospital, I'm not really sick.
Yeah, I mean, there's no reason for her to still be here because he already ran away.
Yeah. So she would be with the social worker maybe in another part of the, non-patient care emergency department, but she wouldn't be taking up a bed space because they're so precious.
Yeah.
Disgusting things bites a patient, and we get a case of hantavirus. Guess who's gonna have to answer for that one, Chief?
I don't even know what kind of infection rat bites give you.
Probably just bacterial infections,
Yeah.
and
Just general
rats
bacterial.
are actually too small for rabies. So not to say they're too small for rabies, but they don't survive long enough to like bite somebody else. You don't really get
Oh, is that
rabies.
why? No, I just-
Yeah, so like
that
small
was-
mammals. These are the kind of things I have to know. But small mammals, squirrels and like rats, like they don't get transmitted to like humans. There's no documentation, like no cases of that. She's mentioning
Bats have rabies and they're small.
That's true. That's a good point. I don't know why is it that bats do. Yes, you're correct.
Is it based on the size or is it based on some other factor?
Maybe something else. I have to look it up. But yeah, rats don't, but bats do. You're right. Bats are a risk, in America especially, they're one of
The highest risk.
Yeah, one of the high risks of rabies transmission. Hantavirus, she's saying, is a disease that is associated with rats. It's a virus. It's a hantavirus. It comes out of the dried aerosolized particles from the droppings of the mice or rats. And someone famously just died in the news from that.
Hey, been looking all over for you. We need a cardiovert unstable AFib in North 1.
Okay, just give me a sec.
Systolics 90.
Fuck me.
35-year-old RP.
Yeah, I barely have time to pee on my shift. If I pee one time on my shift, that's my goal. I just have to pee once on my shift tonight. It's like,
Bladder control.
yeah.
How much did you vape last night?
A couple of pods.
Vape every day?
I do, but not that much.
How much nicotine is in a pod? Anybody know?
No idea.
40 milligrams, same as a pack of cigarettes.
Wow, 2 packs in one night.
Charged.
Clear? Bingo.
Sinus rhythm? Cycle BP?
Yeah. The vapes do have like a ton of nicotine. They're like ultra addictive.
Really?
Yeah. Like much, much higher than cigarettes.
The nicotine causes a lot of like tachycardia and like that's increased heart rate. Anything that increases your heart rate, someone can have. He had basically an unstable cardiac rhythm where it was too fast. And once you're unstable, that's an indication to do the electrical cardioversion. It's the same type of thing that we do for cardiac arrest when someone dies. You're doing CPR, but it's a different dosage of the electricity. Oh, so sad.
Mm-hmm. They should have taken the tube out by then.
No, we can't.
Really?
Yeah, we don't, because it's the corners. Any tubes that we put in, we have to leave in.
Oh, really?
Yeah.
I did not know that.
We try to like, cover things up as best we can. Things that like probes you can take off, but like if you intubate them, you can't remove
I
it.
mean, that kind of makes sense for the coroner, but it seems usual.
Please take some comfort in knowing he did not suffer. You have my heartfelt condolences, Jack Abbott.
That's a really nice letter.
That was a very nice letter. Who wrote it?
So what happened was the patient coded and died before his shift. It was the doctor before him. So usually when you give bad news to family about like a patient that dies, it's usually the doctor that takes care of them that goes in and gives the news.
Right.
But since our field is shift based, when our shift is over and they're still looking for the family members, they don't know when they're going to come, you don't wait around because you have to go home and rest.
Mm-hmm.
If it was like the family's there at the end of my shift, they're just waiting, I'll stay and talk to them, but you don't wait for unknown. Mm-hmm. So he wrote a letter. I mean, I've never done that. I've never written a letter. We've had to definitely give bad news to other people's patients before though.
Yeah.
I do not appreciate you calling me fruitcake.
Oh, did I hurt your feelings, cocksucker?
That said, it has a certain whimsical quality to it that I could probably learn to live with.
Whatever you say, fruitcake.
Excuse me, doctor. My father's starting to struggle again.
He hasn't been able to log in or pee. Sometimes my days are like that though.
Yeah.
Do you know those things will kill you?
Not that lucky.
What the fuck? Hey, they're stealing our rig! You believe that shit?
Happens.
Oh, I've never seen anyone steal an ambulance.
Wait, like a person or?
Yeah,
Like
she said someone stole an ambulance.
If we extubate, we would keep him on oxygen for comfort. We would decrease his sedation. He might regain consciousness. He could recognize you, maybe even speak. I'm sorry, but if there was anything I could do to heal your father, I would do it. But the most humane thing that I can do for him is to allow him a painless, peaceful passing.
Good episode.
Yeah, it's just kind of a continuation of a lot of what they're addressing, like the taking the breathing tube out, that's called extubation, and like the brain death exam. A lot of that's going into the field of more in ICU medicine, intensive care. We don't have many opportunities to do that stuff in the emergency department. I think it would be, like rare exceptions would be like if there's absolutely no beds in the upstairs of the hospital and they just stay in the emergency room for days or something.
That happens all the time.
Yeah, then maybe someone would have to come and do a brain death exam in the emergency room, but I've never ever seen them do an brain death exam in the emergency room. We've definitely extubated patients before. That happens once in a while, not commonly. And then the talk about the resident being a slow-mo, that is a real thing. We do feel an intense pressure to try to push ourselves to work as fast as possible because there's just so many patients, and you have to remember the patients in front of you, but also the line of patients out there that haven't yet seen a doctor, and someone is really truly has an emergency and can be time sensitive. So the more time you spend with the patients in front of you, that's the less time you're giving to the patients after them. So it's pressure. It's one of the reasons why I think personally, like I could burn out from medicine or internal emergency medicine, is this pressure to keep going faster and faster and faster, because you sacrifice things when you go faster. You sacrifice time with the patients, time talking to them. You can't be as thorough, and people don't feel as well taken care of when their doctor isn't sitting there holding their hands, talking to them for a long time. So it's like give and take.
I mean, well, to be fair, that's kind of like an artificial constraint. The reason that you had to be fast is because the hospital wants you to see as many patients as possible.
Right.
So usually the ER is also like privately owned by some group, so they also expect you to see as many people as fast as possible. Meanwhile, all the regulation from CMS and otherwise expects you to be slow and perfect and never make a mistake, which is just completely dichotomous and impossible.
Two different goals.
Yeah. So the regulators expect you to be perfect. Meanwhile, your bosses or your organization or whatever you want to call it expects you to be super fast. And also society too. I mean, helps society if you were fast. But it's just impossible. You can't do both.
Yeah, that's absolutely right. So that's one of the pressures of our work. And this episode wasn't too upsetting, I guess.
No,
it's kind of a continuation of the rest. But I hear episode 4.
It's like an episode of 24. It's like just like one continuous.
That's the whole point of the show. But I heard episode 4 though. People said wait till episode 4. So I don't know what's gonna happen. Thanks, guys. Thanks for watching.